என்னோட ஸ்கிரீன் ஸ்டாப் ஆயிடுச்சுங்க சார்.
ஸ்டாப் ஆயிடுச்சு தினேஷ்.
அவர் சித்தார்த் செக் பண்றாரா? சித்தார்த் செக் பண்ணிட்டாரா?
Unmute, Dr. Siddharth, please unmute.
Yes, sir. I'm sharing my. Okay, someone else is sharing.
Yeah. President, it is only 3 minutes.
Sir, good evening, Dr. Madan here. Am I audible, sir?
Yeah, you're
Yes,
audible.
yes.
Is my screen seen, sir?
Yeah, clean.
Yes.
Just a moment, sir. I'll just check one of the videos. Yes, sir. It's playing.
Okay.
Yeah, it's playing.
Okay, sir. That's fine, sir.
Now you can close, sir.
Okay, sir. Right, sir.
Siddharth can check.
Yes, sir. I'm sharing my screen now.
Yeah.
Is it seen, sir?
Yeah, same.
Yeah.
I just put a slideshow. Yes, sir.
Okay,
I
fine.
think.
Okay, fine, sir. Fine.
Thank you.
President, we can start within a minute.
Yeah. Okay, we'll start, sir.
Yes.
Yeah. Good evening and welcome, everyone. This is from Pudukkottai ISA Pudukkottai Budan 35th episode. And today we have pain management in pediatrics. I invite our Secretary, Dr. Periyasamy. Dr. Periyasamy, please. Dr. Periyasamy. Hello.
President, then we can go ahead.
Yeah.
So
It is I will start, sir.
yeah.
Welcome.
At the outset,
Welcome. As President of ISA, I welcome our academic chairman, Dr. A.L. Meenakshi Sundaram sir, for this today's CME. We have interesting personalities today. We have my friend, Dr. Krishnan, a pediatric anesthesiologist from Institute of Child Health, Chennai. A dedicated and devoted person. I am watching him from his MD anesthesia. Welcome, sir. Today you are the chairperson of this event.
Thank you.
We are very privileged and very happy to welcome you, sir, Dr. Krishnan.
Thank you.
And today we have 3 topics. 3 enchanting speakers are available here today. I welcome Dr. Dinesh Kumar Gunasekharan from Coimbatore, pediatric anesthesiologist. We'll talk on acute pain management in pediatrics. And the next speaker, Dr. Madan Pandian from Puducherry, an interventional pain specialist. He is going to talk about essential pain interventions for anesthesiologists. And last and not the least, Dr. Siddharth M, who is doing fellowship in cardiac anesthesiology GKNM Hospital, Coimbatore. He is going to talk on thermoregulation in newborn. I welcome all the speakers for this today's meeting. I welcome all the delegates who are assembled here, office bearers of ISA Pudukkottai State Branch and India. We have TNMSC credit points for this meeting, and those who want credit point, we can avail that. And regarding the question and answers, you can put your questions in the chat box, and the discussion will be at the end of the three topics. I now hand over the proceedings to.
Sir, I am Doctor. I am here. I am here. Can I?
Dr. Alam, sir, please.
Mr. President,
Yeah.
Dr. Periasamy has entered, our
Okay.
Secretary ISA Pudukkottai. So I request him to say a few words as the welcome address was delivered by you.
Yes, sir. Thank you, sir. Good evening to all. Respected Academic Chairman Dr. A.L. Meenachundram, sir, President Dr. Suresh Kumar, sir, Treasurer Dr. David, and members of ISA Pudukkottai and delegates. I welcome you all on behalf of ISA Pudukkottai for this online webinar program, Pudukkottai Budan. This is the 35th program. So we are conducting this program from March 23rd onwards, and we entered after so many weeks with so many topics. Today we entered 35th program continuously. This credit goes to our academic chairman, Dr. A.L. Meenachundram, sir. At this juncture, I would like to thank him for his continuous effort and hard work for making these programs very successful in India. Very successful in India. Today we are having three topics. One is acute pain relief in pediatrics. Another one is essential pain intervention for anesthesiologists. And third one is thermoregulations in newborn. So for these topics, I welcome our chairperson, Dr. N. Krishnan, Professor MMC Chennai, Chief Anesthesiologist, Institute of Child Health and Hospital, Chennai. As a chairperson, I welcome you, sir, on behalf of ISA Pudukkottai.
Thank you, sir. Thank you.
And next, I welcome and invite Dr. Dinesh Kumar Gunasekaran, Consultant Pediatric Anesthesiologist, Coimbatore. Sir is going to talk about acute pain relief in pediatrics. I welcome you, sir, on behalf of ISA Pudukkottai. And next speaker, Dr. Madan Pandian, an interventional pain specialist, Pondicherry. Sir is going to talk about essential pain intervention for an anesthesiologist. I welcome you, sir, on behalf of ISA Pudukkottai. Next person, Dr. Siddharth, a fellowship in cardiac anesthesiologist, GKNM Hospital, Coimbatore. Sir is going to talk about thermoregulation in newborn. On behalf of ISA, welcome. I welcome you all for this 35th ISA online webinar program, Pudukkottai Budan. So today we are having topics related to pain. So small poem and before that, already is mentioned by our President Dr. Suresh Kumar, sir. Our online program is attended by Tamil Nadu Medical Council, and they are giving credit hours for the delegates, those who are attending the program. For that, those who want to this credit hours, 100 rupees to be paid to our mention this account number. Along with that, we need your identification, phone number, mail ID, and your contact number and your attendance certificate. Screenshot of your attendance certificate. Those details that you send to ISA Pudukkottai at yahoo.com. And today we are having pain management related subjects. So smart poem about that. Pain. no place to hide and no one to escape from pain. It may hurt, go deep and stop the heart, stab the heart. Restless days with the sleepless nights sink into depression because of pain. Intense and everlasting pain suffocates, make breathless everyone. Pain never fade away if peace of mind go away. Pain brings new birth and pain brings new life sometimes. Better cover the free nerve endings with the back of medicine. As a doctor, better cover the free nerve endings with the back of medicine. Pray for strength over this feeling and look for divine healing. May your presence be hope to those in pain. May your presence be hope to those in pain. May you know the healer of all. You always heal and be healed. With this, I thank you everyone for this opportunity. Over to President Dr. Suresh Kumar sir.
Thank you, Periyaswamy. I hand over the proceedings to our academic chairman, Dr. A.L.M. sir.
Respected President, ISA Pudukkottai, Secretary ISA Pudukkottai, and distinguished members, the great faculty, core faculty from Tamil Nadu and Pondicherry. I welcome everyone. And see, the Pudukkottai Budan is continuously happening every week because of the support across the country. And today we have three speakers. The can call that is Indian Madan, pain specialist Pandi. He is a man Pondicherry, doing everything, and he has so many national and international publications. The best point of Dr. Madan will be he's a certified interventional pain sonologist, and he is a fellow from the World Institute of Pain, United States of America. And he is registered in musculoskeletal sonography and a fellowship from APCA, USA. And he is a fellow in Asculap Academy. So, yeah, anesthesiologist taking keen interest in musculoskeletal pain is something different. And really, he is going to give a feast, academic feast for us, because this musculoskeletal pain is definitely a good topic, and mainly people will be suffering from chronic pain involving musculoskeletal organs, and he is a pioneer in that. So I welcome him. And the second speaker will be Dr. Dinesh. So he is a giant in pediatric anesthesiology. So even though it is pediatric, he has a variety of national and international exposure. If I start enumerating his international exposure, then it will be a problem for me, because I cannot even spell the countries he has visited. So he has visited Tanzania, Europe, United States. In United States, he has visited Ohio, California, and Colombia. Why I am reciting all these three places? I have even visited that. So I can say these three places. He has visited United Kingdom, South Africa, and even he has visited Basel. And in India, he has variety of exposures, starting from Dr. Ramesh, who is known across the country. So with his essential knowledge in pediatrics, they are going to arrange a IAPA Academy in Coimbatore, which he will mention during his speech. So as a youngster in the program, we have Siddharth. He is already qualified in anesthesiology, but he is doing his fellowship in cardiac anesthesiology. He is already a fellow in pediatric anesthesiology. So he is going to talk about thermoregulation in a newborn. To cap up all, we need a good chairperson, and it is none other than Dr. Krishnan, who is a professor of Madras Medical College, and he is a chief anesthesiologist, Institute of Child Health. From the very beginning of his career, he has dedicated himself to pediatric anesthesiology. And in Tamil Nadu, not only in Tamil Nadu, across the country, if you name a few pediatric anesthesiologists, Dr. Krishnan will be one among them. He is more knowledgeable, dedicated teacher, but he is very humble and he will not project himself in the meetings majority of the times. He is academically inclined, and over all these things, Dr. Krishnan happened to be a batchmate for me in diploma in anesthesiology. He moved to Madras Medical. So you can start. So in that way, Dr. Krishnan paved way for me in MD anesthesiology. The surprising fact is, even though he is a classmate of me in a DA, MD for 6 months, he has become more intelligent in spite of me by the side of him. That is the trademark of Dr. Krishnan. So he always keeps smiling, soft-natured, and he always gives a tender care to the children. So these 4 people are going to give a good feast for us. So I welcome all the 4, and I now hand over the proceedings to Dr. Krishnan to conduct.
Thank you, Dr. Meenakshi Sundaram, for a nice introduction. At the outset, I'd like to thank my friend, Dr. Meenakshi Sundaram, for inviting me to chair this session. And today's session, we have 3 speakers. One speaker will be talking about pain, acute pain in pediatrics. Another speaker will talk about chronic pain, musculoskeletal pain, how you evaluate and manage. And to cap up with this, one of the dreaded complications I encountered throughout my 30 years in pediatric anesthesia, the problem of hypothermia. So, hypothermia is very, very, very important for any anesthesiologist, more so for a pediatric anesthesiologist and more so for a neonatal anesthesiologist. So without wasting much time, I now invite Dr. Siddharth, fellow from cardiac anesthesia in GKNM hospital, who is going to enlighten us about the thermoregulation of in newborn. Dr. Siddharth, you can start to share your thoughts and your slides.
Yes, sir. Are the slides visible, sir?
Yeah, it is visible, Siddharth.
Clearly audible. If at any time I'm not audible, kindly let me know.
Yeah, your background is there, but slide is not at reach.
Yeah, it will come, sir. Yeah. கல்வி கற்றுக் கொடுக்கும் அனைத்து ஆசான்களுக்கும் என் முதல் கண் வணக்கம் மற்றும் மரியாதைகள். Good afternoon or good evening all. I am Dr. Siddharth, currently doing my fellowship in cardiac anesthesiology in GKNM Hospital, Coimbatore. And for the next 10 minutes, I'll be talking about and walking everybody through thermoregulation in newborn. So the agenda of this meeting will be, number 1, to know the source of heat production in a neonate. Number 2, how they lose their heat. Number 3, how they are different from an adult. Number 4, what is the effect of anesthesia. Number 5, how the regulation of heat production and loss occurs in the neonate. And finally, just to touch upon a small topic which I've also encountered, it's hypothermia in neonates. So whenever I start any of my pediatric talk, I will always be reminded about my mentor, Dr. Ramesh. And this is something which he always tells me in the OT. That is, a child is not a miniature adult, an infant is not a miniature child, and a neonate is not a miniature infant. So the normal newborn temperature is around 36.5 to 37.5 degrees Celsius. And when it goes a little bit down to 36 to 36.5, it's called cold stress. Moderate hypothermia is when the temperature is anywhere between 32 to 35.9, and less than 32 degrees Celsius, the child is going in for severe hypothermia. So how does a neonate produce heat? Number 1 is by its metabolic activity, including the brain, the heart, the liver. All the energy is production by oxidation of fat and protein, which is maximum. Next is by voluntary muscular activity, that is crying, grimace, voluntary movement of the limbs, etc. Third will be vasoconstriction. And fourth and most important of all, which is the difference between an adult and neonate, is non-shivering thermogenesis, that is brown fat. So first we need to know the effect of temperature on neonate. So it is very critical that we maintain a thermoneutral environment for a neonate. So the child needs to be in an ambient environment temperature. The ambient environment temperature is the temperature at which the neonate is able to maintain its body temperature with minimal metabolic rate or oxygen consumption. When the child is in a thermoneutral environment, all the calories are diverted towards the growth and development rather than being exhausted for thermoregulation. So on the end, what we expect is the temperature will be heat gain minus heat loss. That will be the end point of the temperature in a neonate. So how does a neonate or a child lose heat? Number one is by conduction, that is transfer of heat exposed to the body. Number two is via convection, exposure to environment, cooler, AC, etc. 3 is via evaporation, and 4, but not last, is by radiation, that is transfer of heat without any direct contact. So what is the main difference between a neonate and an adult? Number one is a large surface area to body mass ratio. They have extremely reduced amount of decreased subcutaneous fat. We need to understand that heat production is directly related to the body weight of the child, whereas heat loss is a function of a body surface area. So let's say that we have a neonate or a preterm. So the body weight will be less. So the amount of heat that they're going to produce will be less. But comparatively, the body surface area will be more. So their heat loss will be more. So they are more prone for hypothermia. And as in all cases, our safety margin for any pediatric population is very, very less. So we need to be very vigilant. They have a greater body water content and immature skin. And finally, they have a poorly developed mechanism of shivering thermogenesis. So what is non-shivering thermogenesis? So it's basically production of heat by metabolism that occurs in the brown fat. In the left, you can see the distribution of brown fat, mainly in the nape of neck, interscapular region, the sternal region, etc. So it's called brown fat because of the high amount of mitochondria in it. So thermal receptors transmit impulse to the hypothalamus, which secretes noradrenaline, which is taken up by the brown fat. And this chemical process in turn leads to heat generation. So now if you see this diagram, this will basically tell about how heat is produced in a brown fat. So if you see the top right corner, you can see noradrenaline coming and binding to the beta adrenergic receptor, which activates G protein. This G protein will in turn convert ATP to cyclic AMP, which will then go on to activate protein kinase A. This protein kinase A will stimulate hormone-sensitive lipase, which converts triglycerides to fatty acid. All of this occurs in the cytosol. When these fatty acids are being taken up by the mitochondria, fatty acid oxidation takes place and protons are produced, that is H plus ions. Next, from then the H plus ions are transported into the matrix via two mechanisms. One is via the ATP synthase, and another one is via the uncoupled proteins, which you can see UCP there. When this occurs, heat is produced. So this is basically the mechanism by which heat is being produced in brown fat, that is non-shivering thermogenesis. So what are the causes when there is less amount of brown adipose tissue? Number one will always be prematurity. There will be less body weight, increased body surface area, very thin, low amount of subcutaneous fat, and the amount of brown tissue will also be less. Next will be intrauterine growth restriction, and finally will be exposure to prolonged cold stress. So this is the normal temperature, and above and below how our body compensates for it. So let's say 37 is the normal temperature. If you go above it, you will usually start sweating, and even more above it, vasodilatation takes place. Now, if you go below it, number first step will be vasoconstriction, then non-shivering thermogenesis, and then shivering will occur. All of this is just to make sure that heat is produced. Now, how does this vary during general anesthesia? So there are usually three phases. One is phase of redistribution, where there's a maximum loss of temperature, can be anywhere between 0.5 to 1.5 degrees Celsius in the first 1 hour. Then will be the linear phase, where there will still be a loss of heat because the heat loss is more than the heat that is produced. And finally, there will be a plateau phase where heat loss will balance with the heat that is produced. So these are 3 phases that usually occur during general anesthesia. The main thing is the plateau phase, that is the phase 3, will come into effect because of the thermoregulatory vasoconstriction which usually takes place. Now, the problem is in children, and also more important in regional anesthesia, that stage 3 of plateau will not occur, and the child will keep on losing heat because there's no thermoregulatory vasoconstriction. So, in effect, a child is prone to lose heat, and more so during anesthesia. So how do we combat this? So the main thing is, in any pediatrics case, first thing to do is to mainly prevent it. So warm the OT properly, and introp you can give warm IV fluids, you can use radiant heaters, forced air warmers, and all of this should be done properly, and temperature should be vigilantly monitored in any newborn or neonate case. So what are the effects of hypothermia? So this is what we need to mainly do. So as soon as the child is born, there is cold exposure and non-shivering thermogenesis is activated. But if it's not enough, number one is there will be increased metabolic demand and catecholamines will be released. So the child will go and will just use up all the glucose and is more prone to go in for hypoglycemia, and they will have increased oxygen requirement. Next would be they will go in for increased heart rate and increased respiratory rate. And this also affects the surfactant production. So the patients are more prone to go in for pulmonary vasoconstriction, atelectasis, and tissue hypoxia. And in the end, they even have depletion of glucose stores. There's uncoupling of beta oxidation of fatty acids. And these will go and bind to albumin and displace bilirubin. So the child is more prone for what are the symptoms of hypothermia? First is acrocyanosis and cool, molted, or pale skin. They will bring the respiratory distress, apnea, hypoxemia, and metabolic acidosis. Hypoglycemia and bradycardia is very common. There will be decreased activity, lethargic, hypotonia, and finally they will have tachypnea, restlessness, shallow and irregular respiration. This can also have many effects, because when it comes to each and every system, there will be effects. For example, they will be more prone for sedation, they will be more prone for paralysis. However, the drugs which we give will have a heightened effect on them. They will be having poor wound healing, the coagulation will be affected, etc., etc. So the main thing is to be vigilant in a pediatric age group and monitor them extremely closely. So how do you prevent them? Skin-to-skin contact, drying and adequately covering the child plays a major role, especially the head. The head is the major component of the neonates and child's body. So that's where we need to cover so that they don't lose much of heat. Adequate temperature monitoring, keeping the environment warm, and creating awareness. The more you educate people, the more you can prevent hypothermia. So this is cling wraps, which are usually used in the ICU setups to prevent insensible water loss in a child. So how would you treat? So mild cases, skin-to-skin contact will be nice, placing a cap on a newborn head, covering the mother and newborn with warm blankets, and identifying and treating the cause. So basically what we are doing is we need to cover the baby properly, and introp you need to give warm IV fluids, forced air warmers, radiant heaters. All of this can prevent hypothermia. And moderate and severe cases, you should make sure that there's no more heat loss. You need to rapidly warm the baby, and you need to be vigilant in monitoring their temperature. So I hope I have covered a basic about the hypothermia and newborn children, what we need to do and what can be done to actively prevent everything. What we need to mainly understand is that heat production is directly related to body weight, and heat loss is directly related to body surface area. So the younger the child, the more prone they are to hypothermia. And the main thing we need to do is, more than intervention, we need to prevent it. And these are my references. And I would like to finish by saying something which my mentor Ramesh would always keep on telling me, that is, when you're anesthetizing a child, you're also treating the entire family. You are responsible for their hopes and dreams. So never forget that. Thank you for this wonderful opportunity.
Thank you, Dr. Siddharth. It was a very nice presentation. And we have seen so many cases of hypothermia. And one of the very important problems we face with hypothermia is these children go for a severe pulmonary vasoconstriction, dynamic pulmonary vasoconstriction. When they go for hypothermia, There will be reversal of shunting at the level of PFO and PDE. So it's always essential to keep monitoring the pulse oximeter saturation, because that is the one that will kill immediately the child. Something like your transitional circulation, more so in your surgical units. Okay, thank you. It was a nice presentation. As per the guidelines, questions will be asked at the end of the third speaker. Okay.
Yes.
And unshare your slides. The next speaker will be Dr. Dinesh, who is a good friend of mine, who is also hosting the Indian Association of Pediatric Anesthesia Conference in Coimbatore next year. So he is going to talk about one of the very, very important aspects of pediatric anesthesia, that is how to prevent and treat pain, that is acute pain in the post-operative setting or in the trauma setting. The child cannot say like an adult that I am having pain. It is difficult to assess. So it is your duty to assess the pain and treat the pain accordingly. So now I invite Dr. Dinesh to give you a talk on acute pain management in pediatrics.
Thank you so much for the kind introduction, sir. Siddharth, I think you will have to stop sharing your screen so that I can share mine.
Siddharth, you will have to stop sharing. Dr. Siddharth.
I'm not sharing, sir. It's coming. You're viewing Shivakumar Nachimuthu screen. Something.
Dr. Suresh, could you ask Dr. Shivakumar to
Now it is available. Now you can share, I think.
yeah.
Yes, sir.
Madan, you can now share.
So Dr. Dinesh.
Dinesh, you can share. Yes.
Thank you so much, Krishnan sir, for the kind introduction. And like Meenakshi sir said, Krishnan sir is one of the most eminent pediatric anesthetists in India. And what a lot of people don't know is, I think he has the Guinness Book of World Records for removing the maximum number of foreign bodies from children. So thank you, sir. Thank you for the kind introduction. Thank you, ISA Pudukkottai branch, which is one of the most active branches in Tamil Nadu, for organizing this meeting. Thank you. And thank you so much, Meenakshi Sundaram sir. We've always attended your sir.
There was some issue with the audio. Now it is better. Your audio is better.
Okay, sir. We've always attended jam-packed sessions of Meenakshi Sundaram sir, and we grew up as postgraduates, seeing your talks, attending your talks. We used to stand in the lab behind with no seats, a packed house, and listen to your talks. Thank you so much. It's now a very happy moment to be presenting in front of you. So getting to the topic, my topic for today is acute pain management in pediatrics. So generally, we're going to be talking about the principles and what is trending these days in pediatric acute pain management. So I bring greetings from GKNM Hospital, Coimbatore, from where we work. It's a 650-bedded hospital with 100 exclusive beds for pediatrics. We all know that pain is an unpleasant sensory and emotional experience associated to a real or potential tissue damage. We also know that pain is the fifth vital sign. And as far as children are concerned, pain is a very subjective experience. It varies from kid to kid. And kids these days are very sensitive to pain than what we were actually. And it's most probably the most frightening experience any kid will have, pain. Despite its prevalence, pain in infants, children, and adolescents is often underestimated and undertreated. This is a study which says approximately 50% of inpatients were at any time experiencing moderate or severe pain on an average day. And this study compared a study done in 1992, and they said there was no change in practice from survey performed 16 years earlier for what we treat children. And from a kid's perspective, this is actually a real drawing done by a child of how she was experiencing pain actually. So this is the severity of pain, how the kids experience it. It's from the patient's side. So our first thing is primum non nocere, where failure to treat a child's pain violates the first rule of medicine. And as far as a parent is concerned, first நல்லா diagnose பண்ணிட்டாங்களான்னு first பார்ப்பாங்க. அடுத்து வந்து பாப்பாக்கு இந்த ப்ரொசீஜர் பண்ண வலிக்குங்களா. So second, always a patient's second highest parental priority is correct. First is correct diagnosis and second is pain control. And according to the difference from the previous thought, the immature nervous system in pediatric patients results in them experiencing more pain in response, not less pain. Most of the children get delivered is nothing but Brutocaine, where nothing is delivered to them. So there were a lot of pain societies, the American Pain Society, the World Federation of Society of Anesthesia, the European Pediatric Anesthesia, the IASP. The most active one is the Society of Pediatric Pain Medicine in the US. And I was lucky enough to attend their first ever meeting in Florida. So the goals of effective and appropriate pain management are to improve the quality of life for the patient, facilitate rapid recovery and return to full function, reduce morbidity, and the next most important thing is allow early discharge from the hospital. And the long-term negative effects, which sir is going to talk about, are mostly chronic pain and behavioral changes in the children. So the type of pain a child may be experiencing can be either somatic, visceral, neuropathic. But children, most often times, they experience more than one type of pain. It could be somatic and visceral combined, or somatic, visceral, and neuropathic all together combined. So that is why it is even more severe in them. So how do we actually assess pain in children? There are a lot of even confusing books about how to assess pain in children. Number of pain measurement tools exist: PIPP, Comfort, FPS, DCHPT. There are so many numbers of measurement tools which exist. So it is very confusing. And these pain algorithms, I think nobody can remember it until we have it stuck in our operation theaters. So one simple practical way which we follow is newborn to 3 years old or till the child can articulate by themselves, we use the Comfort or Flax scale. And once beyond 4 years, when the child is able to converse or we can articulate with them, we use the facial pain recognition scale. So what is FLAC? It's nothing but we take the face, leg activity, cry and consolability. We have each maximum score up to 2, and a 10 is a maximum pain and 0 is no pain at all. And then we have the facial recognition, which we all know. When the kid can recognize, they can always tell us at what level of pain the child is in. So these two, if we follow, more than enough, very easy to measure than all the confusing number of tools which we have. So just Comfort and facial pain recognition scale. So what is the strategy? How are we going to control the pain? There are so many confounding factors. A male can feel more pain, a female can feel less pain. There are 4 age categories: the physical, mental, and genetic. This thing of the child can cause a difference in the pain perception, and previous experience to pain can again cause different in pain perception. And there are 21 surgeries, 2,500 procedure codes. So each surgical procedure might have a different pain causing level. And from our side, we have 5 classes of anesthetic agents, 3 classes of analgesics, 10 classes of adjuvants, hundreds of local and regional techniques, and other acute pain strategies. There are psychological and physical methods. There are so many confounding factors as far as pain is concerned. So a simple approach is the pain prevention and intervention, the 3P approach, which we all know: pharmacological, the WHO ladder, and the adjuvant treatments. Physical, ice, heat, positioning. Sometimes when the child is having pain, automatically you can see them that itself is a pain relieving thing for the child. Then we have the TENS, then the massage. And psychological, we have education, distraction. Sometimes the child may be shouting with pain. The moment you give a mobile phone to the child, They completely stop crying and they're very comfortable. Those are the distraction techniques. So the main strategy is we are going to attack all the 4 phases of nociception, which is the transduction, transmission, modulation, and perception. At the nociception level, we have the NSAIDs, local anesthetics, the cooling and heating techniques, which can prevent pain. And at the afferent level, we have again local anesthetics. At the level of spinal cord and brain, we have local anesthetics, opioids. And at the level of brain, we can use again paracetamol, opioids, adjuvants, and some psychological techniques. So we'll go in about each technique in detail. We'll start with the pharmacological methods. So the 2022 WHO guidelines, they say go by the clock, go by the child, go by the appropriate route of drug delivery, and go by the pain ladder. So going by the pain ladder, we all know we've been seeing this from our postgraduate days. Mild, you start with paracetamol. The most severe, you give the strongest opioid you have. So as far as the anesthetists are concerned, we have the pre-op period, we have the intra-op period, and we have the post-op period. So we'll see how we are going to go about each. In the pre-op period, there are a lot of books about pediatric pain management. Entire book about pediatric pain management, acute pain management, and I had the opportunity to be in observership with Nationwide Children's Hospital in Columbus with Dr. Tobias, a very famous man with a lot of papers on pain medicine. And this is Dr. Bruno Bissane from Sick Children's Hospital, Toronto. I had the opportunity of observing with him as well for 15 days. So what all of them do is ultimately the same thing. So that is what we're going to discuss now. Preoperative, if the child does not have an IV line, most of them go with an intranasal drug delivery technique. What we are seeing here is a drug atomization. The liquid comes out as particulate material. So the spray, it atomizes the drug and it spreads evenly, very easily available online. So if the child does not have an IV route, the absorption of the drug intranasally is as rapid as the IV route. So a few drugs which we use very commonly for our practice here is fentanyl around 2 micrograms per kg. The peak effect comes in around 3 to 5 minutes. Ketamine we use very regularly, again 2 mg per kg. The peak effect comes in again 3 to 5 minutes. And we use dexmedetomidine, 1, 2, sometimes even 3 mics per kg. One of our postgraduates, she's doing her thesis for NORA, MRI. So Dexmed, intranasal Dexmed for pediatric MRI works wonders. And before we start an IV line, always we know Vlox cream helps if given adequate time. Intra-op, regional anesthesia, very safe. This is Dr. David Polander. This is called the PRAN study, Pediatric Regional Anesthesia Network study, which is a very famous study. It was a large multi-center prospective audit of regional anesthesia in children. And what the study, the PRAN study said was there was very low rate of serious complications when we started using regional anesthesia. So the suggested maximum dose of bupivacaine and ropivacaine, when we give single bolus injections for locals, we can use in neonates, we can use up to 2 mg per kg. In children, both ropivacaine and bupivacaine, we can go up to 2.5 mg per kg. Continuous infusions, post-operative use, maximum infusion rate milligram per kg per hour. In neonates, we can go up to 0.2 mg per kg per hour. And in children, we can go up to 0.4 mg per kg per hour of bupivacaine and ropivacaine, which is most commonly used. Of course, there are the other drugs. And then in caudal epidural, the most commonly used 0.2% ropivacaine. For major abdominal surgeries, we go with 1 ml per kg. For example, if the child is 10 kilos, we go with 10 ml of 0.2% ropivacaine. And we can also use 0.25% bupivacaine, but it has its own complications. We can go up to 1 ml per kg for major abdominal surgeries. Minor surgeries, the same 0.2 ropivacaine, something like infraumbilical surgery, we can go with 0.6 to 0.8 ml per kg of ropivacaine. 0.25, we can again go with 0.6 to 0.8 ml per kg. So the caudal epidural additives most commonly used are clonidine, around 1 to 2 mg per kg, dexmedetomidine, again 1 to 2 mg per kg. People have also often fentanyl, but most proven clonidine and dexmedetomidine, very safe. The child is calm, the heart is calm, we are happy, the surgeon is happy. So this is another very interesting study which we also see practically, effect of dexamethasone in combination with caudal anesthesia on postoperative pain control. So it is not caudal dexamethasone, it is IV dexamethasone. So when we combine IV dexamethasone in children, 0.1 to 0.5 mg per kg, plus when a caudal block is given, the IV dexamethasone augments the intensity and duration of postoperative analgesia without any adverse side effects. So we very commonly we've started using dexamethasone. So next thing we have in our armamentarium is nerve blocks. Of course, like Siddharth was mentioning, always our boss has these very interesting words where he says, as far as nerve block is concerned, as far as a nerve is concerned, whenever possible, wherever possible, you have a nerve, please do block it. So we've been trying to practice that and preach that as well. We preach what we practice and we practice what we preach. So there are a few things which we don't know that we don't know. For example, opioids, it affects the entire body. So what is the point of giving just for a small circumcision surgery, loading the child with opioids? The child is going to take a lot of time to recover. The feeding time is going to be delayed. So a lot of issues. So whenever not necessary, please avoid opioids. Whereas you see in an epidural or a neuraxial block below half of it affects the region of the body. And when you give a peripheral nerve block, it affects the limited region of the body. And when a local nerve block is done, it affects only the local surgical site. So accordingly, we plan and we give our anesthesia. Peripheral nerve blocks, there is a lot of evidence. As a result of low rate of complications, regional anesthesia techniques have a good safety profile and can be used to provide postoperative analgesia. In addition, the results should encourage anesthesiologists to continue to use peripheral instead of central caudal blocks as often as possible when appropriate. So what they're trying to say is, for a circumcision surgery, a caudal block might not be necessary. A penile block is going to give a more denser block and it's going to have a lesser rate of complications. So take it as peripheral as possible. So the most commonly used peripheral blocks that we do for head and neck surgeries, we use supraorbital nerve block for craniotomy, VP shunts, and plastic surgeries. Use infraorbital nerve block, and for cleft palate, we have the greater palatine nerve block. I have an interesting story actually. In one of our smile train camps, when we were abroad, and it was a very periphery and remote area. So we didn't have access to any opioids after a point of time. Whatever stock we had relaxants, we had some propofol, we had the tube, but no opioids. So ultimately, what we did was we just gave them greater palatine blocks, we just gave them infraorbital blocks, relaxed them, tubed them, done with the surgery, very comfortable children with no opioids at all, just the nerve blocks. This is Dr. Suresh Sandhanam. He's a very famous man as far as pediatric nerve blocks are concerned, and especially upper extremity blocks. So we also do a lot of brachial plexus blocks in children, mostly axillary, interscalene, and supraclavicular for shoulder surgeries, forearm and hand surgeries. We also do a lot of wrist block and finger blocks. The next, for abdominal surgeries, very commonly transverse abdominis plane combined with rectus sheath. Rather than transverse abdominis plane block alone, when we combine it with the rectus sheath block, the pain, the analgesia is much better. So it's mainly given for abdominal wall and laparoscopic surgeries. And for newborns, preterms, we can just go with an ilioinguinal block for hernia or groin surgery. And sometimes when we have to do orchidectomies, we can go with spermatic blocks. And the common lower limb blocks, we use femoral block for thigh biopsy and knee surgeries where the muscular disorders and malignant hypothermia, all those things may be a concern. We can just get done with a lower extremity nerve block. Recommended sciatic and popliteal sciatic for foot, ankle, and knee surgeries. Especially a lot of ortho procedures are done just under sciatic and popliteal sciatic. We also use ankle blocks in children. So drugs, again, no pain talk can go without sharing a few points about paracetamol. Acetaminophen improves analgesia after minor and major surgery in children. There is a lot of evidence. So whenever possible, please keep suppositories or give IV paracetamol, whatever good, but please do give paracetamol. There's a lot of opioid sparing effect of perioperative paracetamol and NSAIDs in children. So very routinely, we try to underdose the children actually with paracetamol dosing. So what they say is more than 3 months, oral loading dose can be 20 milligram per kg, and rectal, the suppositories that we keep, we don't have to be scared and keep very small amounts. We can go for a loading dose of up to 40 mg. Even for a 5 200 mg of rectal paracetamol actually. And IV dosing, less than, suppose if you have IV paracetamol, if there is doesn't come less than 500 mg per bottle. So less than 5 kgs, they recommend 7.5 mg per kg. 5 to 10 kilos children, they recommended 10 mg per kg. 10 to 50 kilos per kg. And rectal uptake is slower and very variable. Doses of 20 mg per kg are often not therapeutic and takes 2 to 4 hours to reach therapeutic concentrations. Therefore, per rectal dose 40 mg per kg followed by 20 mg per kg doses are recommended. But if at all you have the option of giving IV paracetamol, please avoid rectal paracetamol. The next is NSAIDs. NSAIDs again reduce opioid requirements, improve postoperative pain intensity, decrease postoperative nausea, vomiting. In fact, there are a lot of procedures which we do in newborns, preterms. We try to just use NSAIDs and get away. Ketorol 0.5 mg per kg. There has always been this controversy. NSAID. There are a lot of studies which say now that there are no apparent effects of NSAIDs on the surgeries. In fact, when the surgeon can cause so much bleeding in the NSAIDs, that it's not going to do much. So very liberally we can use NSAIDs in children. NSAIDs and bone fusion, again, operations and again, it has been proved in their own journal, the Spine Journal. There is no evidence of any deleterious effect. 2 retrospective reviews, NSAIDs following pediatric spinal surgery, everything says there is no major issue. And even non-union patient receiving ketorol versus control, there was no much difference actually. So the most commonly used NSAIDs, diclofenac, ibuprofen, and ketorol. And the next commonly used drug is ketamine, NMDA antagonist, ketamine. Ketamine is very, very well tolerated in children at low doses. At low dose, it is not even emetic. And meta-analysis of around 35 RCTs, they say perioperative IV ketamine has overall decreased pain intensity and analgesic requirements. And in fact, even ketamine is administered locally for tonsillectomy, decreases the PIC analgesic requirements. So ketamine is more like an old wine in a new bottle. For pain, we start with IV. 0.25 at 0.25 to 0.5 mg per kg. The child is very comfortable, no issues, no vomiting. Child is pain-free. And sometimes we go with infusion also, around 50 to 500 mics per kg per hour. And ketamine can be given in any route: oral, subcutaneous, IM, intraspinal, epidural, rectal, intranasal. So ketamine is coming up in a very big way these days. So after 40 years, again, ketamine, the popularity of ketamine is increasing abroad and in India as well, with a proof of a lot of studies. And the next best drug we have in our armamentarium is dexmedetomidine. Dexmedetomidine lowers the risk for post-operative pain and reduces post-operative opioid requirements, especially when we have to give cocktails for tonsillectomy, when all the other drugs have failed, when the child is shouting, or when you have to get away. Dexmed helps a lot. Opioids, yes. If all else fails, we go to opioids. Opioids remain the most powerful and widely used group of analgesics. They can be given by many routes of administration as well. They're very safe, provided accepted dosing regimens are used and appropriate monitoring and staff education is in place. So the general rules for narcotics, IV or nasal administration, it takes around 3 to 5 minutes to peak. If you have to give a subcutaneous or IM, very rarely, 20 to 30 minutes. Oral, it takes around 60 minutes. The fentanyl lollipops, and now we have a lot of fentanyl chocolates. So all these take 16 minutes. Peak effect takes around 16 hours.
Dinesh, you're having problem with audio.
And sorry, sir. Any better, sir, now?
It is better now.
Okay. So please be beware of opioid-induced hyperalgesia. And we also use a lot of opioids in pediatric epidural infusions. Opioid potency, please be aware of this. Tramadol 0.1 potency, morphine is considered as 1, whereas fentanyl is considered as 50 to 100 times more potent than morphine. And the worst part about fentanyl is even after the analgesic effect of fentanyl wears off, the respiratory depression effect of the fentanyl stays for a longer time. So especially for private practitioners, and when the post-operative setup is not good, we load the child with fentanyl. We think the child is breathing, everything is comfortable, and we leave. Even after the analgesic effect, like half an hour, 45 minutes, 1 hour, even after that, because of fentanyl, the child can go for respiratory depression. So we have to use it very judiciously. Is this wonder it is not, but just because they have remifentanil, they, for everything, every surgery, every procedure, they use remifentanil. It's more like switch on, switch off. It's the one-stop solution which will be in pediatrics, but still it has not come to India. Even after 20-25 years of introduction abroad, we can do a lot of relaxant-free surgery. Malignant hypothermia can be avoided. It's like more like a wonder drug, but wish we have it soon in India. Once we have remifentanil, the whole game of pediatric acute pain will change. Then we have morphine, of course, most widely used and studied opioid in children. Safe and effective in all ages, can be given again by all routes. Continuous or intermittent infusion of the dose is adjusted according to the individual analgesic requirements. So to make infusions of morphine very easily time-tested way, just take 1 milligram per kg of morphine. Suppose the child is 5 kilos, you take 5 mg per kg of morphine in 50 ml of normal saline. And so 1 mg is nothing but 1000 mics. When diluted in 50 ml, you get around 20 mics per ml, and you infuse it at 1 to 2 ml per hour. So final dose delivered to the child, if it is 1 ml, it will be 20 mics. If it is 2 ml, it will be 40 mics per kg per hour, which is the actual infusion dosing of morphine. So the final dose delivered will be 20 to 40 mics. Infusion regimens, again, 0 to 1 month, maximum of 5 mics per kg per hour, nothing more than that. So which will be around 0.25 ml per hour. 1 to 3 months, you can go with a maximum of 10 mics per kg per hour, which is nothing but around 0.5 ml per hour. Children over 3 months, you can liberally go with 1 to 2 ml, that is 20 to 40 mics. And in children as young as 4 years, these days kids are very smart. So patient control PCA pumps can be used by these children. And smaller children, we have abroad and some places in India also, we have this nurse controlled analgesia, where the nurse can control the pump, where even higher doses can be used because we have the nurse to monitor the child. Fentanyl, again indicated for morphine intolerance, especially when the child is undergoing a lot of chemotherapy and they come for repeated procedures. Nausea and vomiting, poor renal function, we use fentanyl. To make infusions, just like morphine, we took 1 mg per kg. We take 50 mics per kg of fentanyl in 50 ml of normal saline. So 50 by 50 gives around 1 mic per ml, and we infuse it at a rate of 1 to 2 ml per hour. And the final dose which will be delivered to the child is 1 mic per kg. Regimens most commonly we used instead of 2 microgram, and we infuse it at a rate of 0.2 to 0.4 ml per kg. Suppose that is 10 kilos, we infuse at the rate of around 2 to 4 ml per hour. But the thing is, always check the dosing is appropriate for the child and give it safely. You will not have any problem. So there are a lot of combinations which work for acute pain in pediatrics. Fentanyl plus morphine, we use a lot in procedures because fentanyl starts acting immediately. And at the same time, even if you give morphine, it will take around 20 to 30 minutes to start acting. So you can always combine fentanyl and morphine for longer procedures, no problem. Definitely you can do it. Dexmed and ketamine, again, dexmed reduces the heart rate, ketamine increases the heart rate. When you combine both, the analgesic potency also, the synergistic effect is much better. So you can combine both. Ketofol, definitely all of you must be using ketamine and propofol. But the only thing when we combine drugs is reduce the dose of each drug. For example, the dose of ketamine is 2 mg, the dose of propofol is 2 mg per kg. When you combine 4 mg into it, it's going to be a disaster. Just reduce the dose. Maybe 1 mg ketamine and 1 mg propofol will do wonders. And we also use a lot of fentanyl. We also use ketamine and midazolam as combinations for acute pain in pediatrics. So common to all procedures, preoperative discussion, importance of pain control. The options must be discussed with the parents and elderly kids. Everybody, comes with a lot of Google experience these days. So give them a chance to, at least express what they have learned. Acknowledge the emotional response of children. Give them a lot of choice. Intraoperatively, go for multimodal balanced analgesia. Use a lot of paracetamol, NSAIDs. Use opioid very judiciously. Use it only when necessary. Consider lidocaine, ketamine, dexmed, dexamethasone. Always try to use local or regional techniques whenever possible. And in PSU, whenever we have a long list, we always try to travel with an opioid in the pocket, and always consider infusions whenever it is possible. So ultimately, the optimal pain management is the right of all patients and the responsibility of all health professionals. So primum non nocere, I think we have to stand by our oath. Thank you. Thank you so much. And GKNM, in association with the IAP, Indian Association of Pediatric Anesthesia, we run a 1-year accredited fellowship course with intake in August and February. Sometimes now even in July and January we take fellowship students, and the stipend is around 60,000. This year, we pediatric conference will be a very different conference. We've planned it in a way that it's going to be India's first sustainable medical conference with a lot of very different, forest themed, wildlife themed conference. I have a small video to show you with the president's permission. So thank you, sir. Thank you so much for the opportunity. The conference is again going to be very postgraduate friendly and very practice oriented, practical conference with all the differences. So try to register, but please do pass the message amongst your postgraduates and faculty, sir. Thank you so much. Thanks for the opportunity.
Thank you, Dr. Dinesh, for an excellent presentation on how we normally do take care of the pain in pediatrics. I think the audience might be having lots of questions regarding how to manage pain. So we'll have all the questions at the end of session. Now we will come to the third speaker, Dr. Madan Pandian from Pondicherry. He's what, as Dr. Meenakshi said, he's one of the excellent teacher and a wonderful person who teaches pain management and more so the chronic pain management. The chronic pain management is one part where much has not been done in anesthesia department, except few places only they do. It requires more patience. So we have a great person, Dr. Madan Pandian, who will be talking to us about musculoskeletal pain and what are the common interventions that can be done by anesthesiologists who are trained in pain management. Now I hand over to Dr. Madan Pandian to give his expert opinion and advice to the students about the essential pain intervention that they can learn during their postgraduate time. Over to you, sir.
Sir, I'm audible, sir.
Yeah, you're audible, sir.
Yes, sir. My screen is visible, sir.
Yes, sir.
Okay, sir. So let's move to the topic, sir. Actually, I am Dr. Madan Pandit from Pondicherry. I am actually a musculoskeletal sonologist and an interventional pain specialist. Actually, after my MD, actually, I've gone through a lot of phases in anesthesia. Then finally, I fixed up with doing pain for some reasons which I'm going to tell you later. Okay. So what is the need to learn? Why does it need to be learned in the department of anesthesiology? Because definitely helps a lot of patients in difficult times with a lot of chronic pain, particularly cancer pain. It ignites young minds. A lot of postgraduates and young assistant professors in each department needs to learn this actually, because it is a very, very viable independent career option. My recent experience, 2006 to 12, I was actually an intensivist. 2012 to 17, back to anesthesia. Again, that is the transformation period which I actually underwent. Went for a lot of workshops and training to understand what is chronic pain. Then actually, when I was actually supposed to speak about chronic pain in a South Zone conference in Pondicherry in 2021, I realized that actually chronic pain management hasn't reached any anesthesia department at all, because the basic procedures actually were not done in all the institutions, particularly in very few institutions where there is an experienced anesthesiologist who can perform these interventions. These are the institutions, hardly you can count it actually. So these are the institutions where some kind of an interventions are happening. So I decided it is my bounden duty to actually make it reach each and every department of anesthesiology before we actually claim it as a super specialty, right? So what are the interventions which we need to do? Always try to do the interventions only image guided. It can be done as a nerve stimulator guided procedure, but with image guidance. Maybe landmark guided, as definitely like with landmark guidance, you will get a lot of poor results as well as complications. So what can you do with fluoroscopy guidance? You can do a lumbar transforaminal epidural. Most of you will be doing a caudal epidural. Again, you can do it as a hybrid procedure, ultrasound plus fluoroscopy guided procedure. You can do a celiac plexus or a splanchnic nerve block and a lumbar sympathetic block. These are some basic procedures any anesthesia department is expected to do, right? So what are the ultrasound guided procedures you are expected to do? A stellate ganglion block, a suprascapular nerve block for shoulder pain. Ilioinguinal neuralgia is a very common indication for ilioinguinal nerve block. Nearly 30% of patients who have undergone herniorrhaphy present with ilioinguinal pain. Intercostal nerve block, particularly who require in acute care as well as chronic pain. Carpal tunnel injection, one of very, very interesting injections which gives a lot of good results, which actually enables the patient stay away from surgery. So what are the other procedures which can be done as an anesthesiologist? Whatever you know the thoracic paravertebral, you know the erector spinae block. These can be used effectively to manage chronic pain. So lumbar transforaminal, how do you do it? It is purely fluoroscopy guided. It is definitely more selective, for which you use a very less dose of steroid. When you use contrast, you can see the vascular runoff. As you know, it can actually cause a steroid embolus if it actually is intravascular. So there is no risk of steroid embolus in this particular case. And the disadvantages are, you need to learn the technique first thing. Second thing is, the patient should be in prone position. Definitely there is an element of radiation and cost which should be taken care. So this is just the fundamentals of how exactly it looks like on fluoroscopy. You can see there is a Scotty dog appearance. You can see there is the eye of the dog. This is the nose of the dog, the foreleg, the body. This is the hind leg, the tail, and this is again the body. This is the ear of the dog. Very classical, which you had actually probably read in your anesthesia, means like in your anatomy books. This is the eye of the dog. Below the eye of the dog, actually getting in your needle and getting into the foramen. Very clearly, it is into the posterior superior part of the foramen. If it is into the posterior superior part of the foramen, inject contrast. If it is not intravascular, the patient doesn't complain of pain by injection, then go for maybe around 2 to 4 milligrams of dexamethasone along with minimal dose of local anesthetic. This is how you get it. Okay, you get a selective nerve root block when you actually give a transforaminal injection. So caudal epidural, where all you can do caudal epidural. You can do it as a hybrid procedure, particularly in patients who actually have a canal stenosis. In patients who present with a mechanical back pain related to canal stenosis, a claudication, a neurogenic claudication pain, such patients actually do not qualify for an interlaminar method. Don't go for a transforaminal. Always do a caudal epidural with a hybrid technique. Always caudal epidural is very much indicated with or without catheter. You can actually do a caudal epidural for a failed back surgery, right? This is what I meant actually. Typically, why do I say repeatedly hybrid procedure is, you could see the sacrococcygeal ligament, which is very, very thick here. You can see the needle entry from caudal to cranial, but as you move, means cranially, you actually cannot see the needle passing beneath this point because there is an overlay of the bony structures here, because of which you cannot see the placement of the needle tip. As you know, the placement of the needle tip is not seen. You are not supposed to actually advance your needle, for which you need to actually do a fluoroscopic guidance. And once you inject contrast, you can see the Christmas tree appearance. This is what exactly I mean as hybrid procedure. Can you see this? Okay. See, you can see the needle entering into the caudal canal. You can see contrast injection giving rise to a Christmas tree appearance. Right. Celiac plexus block. Again, you know the indications. I'm not going into the details much. You can do either a RF ablation. If it is a radio frequency ablation, you can do it in the celiac splanchnic nerve. If it is a celiac plexus you are targeting, you have to do only a neurolysis because it is not a single nerve. You know the indications and as well as the contraindications. Again, patient positioning always a challenge. Patient has to be in prone position, particularly in malignancy. You cannot actually place the patient in the prone position, particularly because the patient is going to have ascites, pain, and difficulty in breathing. All these actually have to be taken into account, right? Just a small little reminder of the WHO analgesic shoulder, WHO analgesic ladder. Okay, typically we know the 3-step ladder. Now it has actually gone on to the modified pattern is the 4th step actually. The invasive procedures or the minimally invasive treatments, which actually makes this actual ladder bidirectional. You can actually give it as the first step or even the last step. So if you actually give it as the first step, a patient who may require a patient with severe pain who may require a strong opioid may actually require maybe a paracetamol or even a tramadol. Suppose the patient actually doesn't respond to your step 3 analgesic, again, you can actually ascend up to the step 4. So typically it has made the WHO analgesic ladder bidirectional. This is the difference between the celiac and the splanchnic nerve blocks. Typically, you have the 3 splanchnic nerves actually getting along at the T11 and T12 level. So at this level, if you do a splanchnic nerve block, you can actually very well target single nerves actually. That is why I call it as the splanchnic nerve block. Whereas at the level of L1, if you do, you can actually see there is a conglomerate. That is a cluster of nerves which you are going to block, which you cannot do any thermocoagulation. So you will have to actually do an alcohol neurolysis. So typically this is how it is done. This is a splanchnic nerve block. This is a splanchnic nerve RF being done, radio frequency ablation under CM guidance. Typically see that you have to take all the precautions of monitoring. Okay, so monitoring, safety, everything should be there. And at the time of injection, you can give a low dose sedation. Otherwise, this is essentially a procedure which is conducted under local anesthetic. I personally prefer to keep an anesthesiologist at the head end. I personally behave as a pain specialist rather than actually a pain specialist come anesthesiologist, because there is a dedicated need for one person who is standing at the head end, because these are not procedures which we are not used to. Patient is in the prone position, you might have to secure the airway, patient might develop a breathing difficulty, all this can happen. Okay, so you do not want any unwanted complications, right? This is how it is done. This is a typical, means the needle, this is the radio frequency needle at the T11 and the T12 level. This is T11, this is T12. You can see the needle tip, actually this is the active tip, which I call it as active tip, is around 10 millimeter, which is the coagulating tip, which is the thermal tip actually. It is at the junction of the anterior 1/3 of the vertebra and the posterior 2/3 of the vertebra. You can see this is RF for you, and this is the alcohol neurolysis after contrast injection. Typically, what you need to know is stepwise positioning of the C-arm, positioning of the patient, then needling, safety, all the time safe, safe, safe. Because do no harm will be the actual mantra here, right? Typically, this is how it is done. This is the thermocoagulating RF probe, which is into the RF needle, and do a conventional radio frequency ablation at around 70 degrees temperature. This is a very interesting picture. Suppose the patient is unable to actually lie down prone. What next I would do? You cannot actually ask the patient to lie down prone for a fluoroscopy guided procedure. So what you can do is you can actually image the celiac plexus with the ultrasonography. Here, this is the L1 vertebra, right? This is the aorta here, and this is the IVC. Can see there is a celiac trunk which is actually dividing into two, the splenic and the common hepatic. And this actually is called as the seagull sign. When you call it as a seagull sign, you could have seen cricket matches being conducted in Australia. You could see the seagulls actually flying up once the ball is hit. So this is typically when you apply color Doppler, you can see a nice little enhancement of this seagull, and that is the point of actually in the injection actually. Just here, okay, it should be pre-aortic. This is aorta, this is just pre-aortic. Okay, next, moving on to some other thing. Okay, this is I think like most of the postgraduates would answer this. This is a complex regional pain syndrome who actually has got a shiny limb, dystrophic limb, lot of skin and hair changes are there. So what are you supposed to do? You're supposed to do a lumbar sympathetic block. Again, going through the indications, can be done for a peripheral vascular disease, TAO, okay, peripheral neuropathies, sometimes refractory peripheral neuropathies, and CRPS. Typically, what you should do is your needle should be at L2, 3, and 4, and it should be at the anterior border of the vertebral bodies. Okay. Most of these things actually are done in our department of anesthesia in Pondicherry Government General Hospital, right? This is a patient who has undergone a humerus surgery. Post humerus surgery, she has developed a shiny limb. Again, this is very classical complex regional pain syndrome. As such, I say, before you actually say like what all procedures I should be doing, typically what you should be having is a eyesight, actually good sight to look at all these patients. Clinical assessment of these patients only you can decide which procedure you require. Stellate ganglion block, again, indications, upper limb CRPS and a sympathetically mediated pain, a post-herpetic neuralgia, sometimes a refractory angina, and there is one incidence where actually I have done actually a refractory VT getting all right with the stellate ganglion block. So typically it is not essentially truly stellate because you are actually going to give it at the C6 level, and the drug which you actually inject, it is going to actually go down along the spatial compartment to the stellate ganglion. Essentially, it is at the level of T1. Okay, a classic picture of how a stellate ganglion block is done. As you all know, this is the C6 anterior tubercle, and above which you have the longest scoli muscle here. This is the longest scoli. Okay, this is the carotid artery, and this is the actual IJV. You can either compress the IJV, or you can sometimes, it is not really advisable. Sometimes you may be permitted to go through the IJV also, not a problem. Typically, you have to stay above the longest scoli muscle, between the longest scoli and the carotid sheath. What are the side effects? Again, you know that Horner syndrome is always a possibility, and that actually indicates that your block is successful. Suprascapular nerve. Again, you can actually do a neuromodulation technique of the suprascapular because it is a mixed nerve. You are not supposed to give a conventional radio frequency ablation because it is a mixed nerve. You can land up with a paralysis. So what you can do a ultrasound guided procedure either with or without nerve stimulator. You can actually see there is a notch. Actually, this is the suprascapular notch, which is actually bridged by the transverse scapular ligament. Okay, and below which you have the vessel as well as the nerve. You can see this is the suprascapular ligament, and this is the nerve. Then there is something called the iliaquinal nerve, which I repeatedly tell people how to do the block is a real challenge here, because most of us actually do the block at the level of the spino-umbilical line. That is the line joining between the umbilicus and the anterior superior iliac spine. So what are the indications? Iliaquinal neuralgia, post-trocar laparoscopic surgeries, abdominoplasties, orchidectomy. Lot of these conditions land up the patient with the iliaquinal neuralgia. So how exactly do you do? Normally, we are used to doing it at the spino-umbilical line, but I repeatedly tell people, if there is a transection at the level of the spino-umbilical line, at the level of the incision, how effective your block will be when you give it at the level of the transection? Definitely it is not going to. So as a pain procedure, as a pain physician, what you must understand is, you must actually trace this more proximally. Okay, this is exactly the place which you are trying to give. This is not the place to give. You have to trace it more proximally. This will be in between the iliac crest, highest point of the iliac crest, and the anterior superior iliac spine. Typically, you have to stay between the costal margin and the anterior superior iliac spine. Okay, exactly this is what I meant. Not essentially at the spino-umbilical line. This is the direction normally which is given. I normally advise people to give it between the highest point of the iliac crest and the costal margin. Typically, there will be one place where you can actually place the probe, and this is the needle coming in play. Intercostal nerve block, again, there are indications. You know that. I don't want to get into the indications actually. Typically, it can be done with ultrasonographic guidance. Okay, you know the structures, the van structures actually under the groove of the rib. Generally, there was only one instance where I could see the intercostal nerve. If actually, like, I don't have the video right now, I can share the video. Otherwise, generally, you cannot see the intercostal nerve. See, this is the plane actually. This is the second muscle, internal intercostal muscle, just above the innermost intercostal muscle. Okay, the incidence of pneumothorax is around 8.7%. You will have a loss of gliding sign and a loss of comet tail artifacts. This is how it is typically done. Okay, you see the artery, apply color Doppler, enter in caudal to cranial, and it actually very important to actually do it very close to the spine of the vertebrae. You know that actually, as you actually go more laterally, all the anterior lateral branches would have actually come out. There is no point giving a more distal block. You will have to give it more proximally. That is the major point actually I want to insist. Okay. Carpal tunnel, you know the indications. You know what are all the problems actually associated with the carpal tunnel syndrome. A neurosurgeon or an orthopedic surgeon or a plastic surgeon who gets you a carpal tunnel syndrome for release, for heaven's sake, please do an ultrasound examination, a diagnostic ultrasound. You will be very fascinated with the findings actually. This is typically how a carpal tunnel looks like. This is the scaphoid tubercle. This is the pisiform. You could see there is a small retinaculum which is the lining there. This is the flexor retinaculum. And you can see the 9 tendons within. There is a FCR tendon, flexor carpi radialis. You can see the ulnar artery and the nerve actually, which is just outside the flexor retinaculum. Beautiful structure. And the lastly, but not the least, actually, the most important, the median nerve. Okay, this is the median nerve. This is our target. You can actually assess the median nerve, how thick it is, what is the CSA, whether there is any R-glass compression. Typically, you actually have to become one. And when you inject into it, essentially, you should not inject anything else. You can inject a steroid, that is okay. This is 5% dextrose hydro dissection of the median nerve. This is the median nerve for you. I'm trying to hydro dissect with 5% dextrose. Typically, what 5% dextrose does is it can actually improve the blood nerve barrier. You can see the hydro dissection of the median nerve. Typically, you start enjoying your procedure the once you get your results, like 2-3 patients you do, you will 100% get good results. You can see there is a flexor retinaculum which is separated. The median nerve is separated from the retinaculum, right? This is under the nerve. So these are all, I call it as office procedures, which can be done as a daycare procedure in all your anesthesia departments. Okay. The acceptance will take a lot of time. Plus, don't bother about all these actually. Critics will remain. Let them remain. Okay. This is a hydro distinction of the shoulder with a posterior glenohumeral joint. This is a small 26 gauge 1.5 inch needle into the glenohumeral joint. I typically use around 60 ml of normal saline, and I do a hydro dissection because this entire infraspinatus tendon, which is sticking onto this cartilage, this is the cartilage, okay, which will be released. There is a capsular release because of that saline injection, okay, followed by a good mobilization. You can inject steroid, okay, fine, no issues. This is a tennis elbow. Actually, I'm giving a common extensor tendon fenestration. And after needle fenestration, I'm going to do a injection into the common extensor tendon, most preferably PRP injections, platelet-rich plasma. These are procedures typically which is like slightly higher end actually. This is barbotage of the calcific tendinitis, trying to inject saline and local anesthetic into the calcific tendon and just trying to aspirate. I'm just aspirating the calcific tendon actually. Okay. Typically, you need to inject small aliquots of local anesthetics to make it painless and then aspirate. When it is in the formative phase, it tends to break and you can actually aspirate everything out. Okay. This gives immediate pain relief without any other pain intervention. This is the calcification which I was telling you. This is the calcification here into the tendon of supraspinatus. Trying to aspirate after injecting a lot of saline and local anesthetic into the cavity. Okay. This is a very, very simple procedure. A patient who is having a painful arch syndrome, somebody who is not able to do a painful, means like a side arm abduction movement actually, you can actually give a steroid injection or even 5% injection just above the supraspinatus tendon into the subacromial bursa. Okay, you might think whether these are all important things which need to be done in an anesthesia department, but these are the things which are done in pain interventions. Okay, so what we need to do as an anesthesiologist is to set up a pain clinic, learn the basics of clinical examination, acquire the skills, and learn to actually do it as a multidisciplinary team rather than working as an individual. This is a simple knee joint injection. I'm injecting PRP injection, okay, into the knee joint for a grade 3 arthritis, osteoarthritis, into the suprapatellar recess. This is hydrodistension with saline, the shoulder joint injection. Typically, see that a lot of critics will remain. People will try to actually blame you when actually there is a problem. See that you don't create any new harm to your patient. Do everything sterile. Particularly your patients who actually come with a problem, do not add on to their problem. That is one thing. Second thing is very, very important. Be sterile at all times. This is a very classic image. Okay, this is the C5 nerve root injection. This is the anterior, and this is the anterior tubercle. This is the posterior tubercle. You can see the nerve root there. There is a needle coming in, and I'm trying to get under the nerve root, just anterior to the posterior tubercle. You have to be very, very precise. You really can't rush. Very slow. This is a live picture. Okay, this is a live picture, unedited. Try to see how slow and steady my needle is. Okay. See, I'm just going under the nerve root here. As I inject, this is only 0.7 ml. The nerve root actually pushes up. Okay, this is only 0.7 ml with 2 milligrams of dexamethasone. This is a plantar fascia injection. Perifacial and the intrafacial injection of PRPs. Again, subacromial bursa injection. See, typically this will help you improve your needling, your imaging, your steadiness of the probe. Definitely, you need to become ambidextrous when you start practicing pain medicine. This is very common thing nowadays. Actually, you can see a lot of people who are having trigeminal neuralgia, but many times we feel a lot of people who are not able to do, even senior pain physicians are not able to do a trigeminal neuralgia. So you need to actually go for some kind of a training. A lot of people are doing it across India. There are at least some 200, 300 people who are doing trigeminal neuralgia ablations. Please learn from them. Okay, you are most welcome to come to Pondicherry to learn this. Okay, we do it free of cost in Government General Hospital. Okay. And then other procedures which you can do, again, I told you, erector spinae for herpetic neuralgia. Okay, post-herpetic neuralgia, all that you can do. This is an SI joint injection. Okay, this is a sacroiliac joint injection. See, to do a sacroiliac joint injection, do not expect your orthopedic surgeon or an MRI to say this is a sacroiliac joint pain. Expect, okay, try to improve your clinical skills, try to manage on your own so that you are able to face the complications and side effects as well. Okay. This is a failed back surgery. This is a cervical epidural. Okay. This is a ganglion implant. This is one of very, very common, easily done blocks actually. You can see there is a coccyx here. Just anterior to the coccyx, you can inject an alcohol neurolytic block for ganglion implant, which can actually give relief for a lot of coccydynias. You can see like a lot of rectal cancers, actually it can give a pain relief. Okay. So these are all the procedures which actually should be done on a day-to-day basis. If you take in a month, at least one procedure per day should be there. And that is what will actually give a lot of awareness on pain management, not only for the public as well as for the doctors. Please follow me on LinkedIn, Facebook, and YouTube. Not for any marketing purposes, because I keep posting a lot of educational videos and clinical cases. Okay, we are coming out with our first international MSK Pain Congress very shortly in January 2023. That's going to be in Pondicherry. I'm the organizing secretary of this conference. Okay, quite a lot of faculties, nearly some 32 faculties, 7 from abroad. Okay, this is one of those landmark and benchmark events to change the landscape of pain management in India. Thank you so much.
Thank you, Dr. Madan, for an excellent presentation. And this would have stimulated lots of PGs who are watching it. So they will become a pain specialist, because one of the chronic pain is one thing that is not much cared for in our part. Hopefully, we'll have lots of questions now. So I think when all the 3 speakers are completed, now we have time for interaction. I think we'll start asking a few questions. Before that, for speaker number 1, about thermoregulation. For the sake of postgraduates, could you just tell them where to measure the core temperature and where to measure the surface temperature? That is for the sake of postgraduate, because there are so many postgraduates I can see here. Dr. Siddharth. Dr. Siddharth, are you available?
Hello, sir.
Dr. Siddharth, just for the sake of graduates,
Yes, sir.
we just tell
Hi.
them where to measure the core temperature and where to measure the surface temperature.
Yes, sir. So mainly for the precision of monitoring, the site is more important. So for core temperature, we can see the tympanic membrane, the nasopharynx, and the esophagus. Those are the most important. And for the peripheral temperature, the skin temperature as such would be equally good, sir. And most important for core temperature would be rectum. Rectal temperature would reflect a more precise thing about the core temperature.
How about the tympanic membrane temperature?
Sir, yes, sir. I told sir,
Ear
tympanic
temperature.
membrane.
No, which is better? Which one you feel is better? Is that one or rectal?
Rectal, sir. Rectal would be better, sir.
Is there any questions for Dr. Siddharth from the audience? Okay, there is one question for Dr. Dinesh from the audience. This is from Dr. Muthukumar. What are the doses of NSAIDs and when used IV and
Sir, most commonly used NSAIDs is diclofenac suppositories, which we use around 1 mg per kg, but we try to use rectal suppositories after beyond 10 kilo children. Less than 10 kilos, we try to avoid NSAIDs suppositories. Instead, we go for IV ketorol, which we use at the dose of 0.5 mg per kg, sir.
Then there is one more question from Dr. Venkatanath. Paracetamol infusion is 0.9% normal saline solution base. In infants, this is too much salt load for immature kidney. Your views?
Very, very, very true, sir. It's a good question. In fact, the dose that we use in these infants is going to be very less, sir. Maximum they're going to be 3 kilos or so 7.5 mg per kg means hardly we'll be using 2 ml of paracetamol and 0.9 normal saline. There is one recommendation which is we can dilute it with 0.5% dextrose. So that we can take the 2 ml of paracetamol, we can dilute it with another 2 ml of 0.5% dextrose so that we reduce the load. That way, that is also recommended. There are a lot of papers which suggest that. Maybe that answers this question, sir.
And then there was one more question from Dr. Spinal anesthesia in infants. How safe is it to use?
So that's for Dr.
In infants. How safe it is? The spinal anesthesia. He's asking spinal for infants.
Yes, sir. Spinal anesthesia is still in use, but the better one is when we have the option of caudal, and if the caudal can work as safe as the only thing, it's about the duration. But I think caudal does well in infants than spinal. Do you agree?
It's just a question of time of onset. Okay?
Yes.
The main problem in spinal anesthesia, it just comes even for baby weekend only for 30 to 35 minutes. So surgeon has to be really fast from skin to skin. He has just to finish. So there are really very little indications, except for a very premature child. And the surgeon is good, fast.
Do you use caudals, sir? Instead of
caudal we use regularly. Caudal that will come for a longer time. But spinal, because this question is how safe it is. It is quite safe. Only thing is the needle should not go up. Like adult, you cannot just keep on going up because you know that spinal cord ends at a very, very lower level in neonate and infants. There's one question from Dr. Kannan Bauraj to Dr. Madan. What is your preference for SA injection, ultrasound or CM guided?
What is the preference
Dr. Madan,
for?
sir?
Yes, sir.
SA joint injection, ultrasound or CM guided?
Sir, this is again one more procedure where the hybrid technique is advisable, because just to want to reduce the irradiation from fluoroscopy, actually, you can go for injection with, if you're doing a diagnostic block, you can do ultrasound guidance alone. If you want to do a SA joint injection by RF, radio frequency ablation, definitely you have to use fluoroscopy, sir.
There is one more question. In tennis elbow, steroids injection around the tendon or intratendinous?
Sir, never any tendon should be injected. with steroids, sir. Typically, it is around the tendon, that is superficial to the tendon. If it is a PRP injection, definitely into the tendon. So necessarily what I tell is, do not actually venture into steroids, particularly for tennis elbow, even though it actually gives immediate pain relief. Definitely there is an amount of actually degeneration of the tendon, even though it is peritendinous. You really can't avoid any single fiber of the tendon because it undergoes degeneration, and later on it may give rise to more pain actually. So that is why typically necessarily what you should be doing is regenerative therapy rather than steroids.
Thank you. And Dr. Dinesh, can we give spinal and have a caudal catheter for post-op pain relief? This is from Dr. Muthukumar. Dinesh?
Yes, sir.
Depends
for what surgery we are doing it, sir. If it's just a hernia, there's no point in giving a spinal and then having a caudal catheter. If it is a prolonged procedure, we can always have the option of an epidural rather than a caudal catheter. So depends on what the surgery is. Yeah.
Chairperson, Dr. Krishnan sir.
Yes, sir. Yes, sir.
Dr. Meenakshi Sundaram. See, I want to know your experience. How we will use spinal with the intramuscular needle or pediatric spinal needle or the adult spinal needle.
Actually,
Dr. Dinesh and Dr. Krishnan, tell us.
So there is a pediatric spinal needle available. The problem is the cost and the availability of the needle. It's very difficult to get. I tried with the BD company. They have said they have even stopped marketing that particular needle. So right now that what is available to us is conventional IV needle for a neonate. But the problem is a dead space because you're going to take only 0.2 ml of the solution. That is what you're going to get it. So you'll have to inject, wait for some time, expect the drug to go inside. So that's what we cannot flush also. So that is the reason why we don't do much, except for babies, we don't do spinal injury ICH. Dinesh, how about your thing, Dinesh?
Correct, sir. I also agree with it. And I think it is moving more towards caudal even for preterms and than spinal. Though spinal is safe, but caudal looks safer. So that is the only.
No, Dr. Dinesh, my idea of asking people, they are comfortable with the spinal anesthesia because it is a widely practiced technique.
Yes,
so
sir.
they feel comfortable. They know what is the end point, that loss of resistance, flow of CSF. But this intramuscular needle, which we used to practice at the time of post-graduation, the moment we push, sometimes the needle, as it is a sharp edge, it goes very easily inside. Then there is no stillet. We cannot predict what is happening. And as Dr. Krishnan pointed out, I want to know the dead space, whether you are using insulin syringe or tuberculin syringe. That way I am asking, so that it will be an eye opener for the younger generation.
Sir, insulin syringe, the length might not be enough, sir. Maybe we can,
how you are doing? I'm just
26 gauge normal needle, sir. Not spinal needle, the 26 gauge needle, only the syringe which we get, we use that syringe for the spinal, sir.
You are having a dedicated syringe, is it?
No, sir. Regular needle.
The normal 26 gauge needle which comes, we use that needle, sir.
The syringe you use is 2 ml or 1 ml?
2 ml, sir, 2 ml.
Then how you take that solution? See, with the 2 ml syringe,
child accordingly.
How you are taking that local anesthetic solution? Yeah.
Dose bigger child, we go with the 2 ml syringe.
No, my internet connection was unstable, so I could not listen to your answer.
Smaller kids insulin syringe, sir. If the child is big and that time for a spinal, we try to use a 2 ml syringe, sir.
That's what you said, that insulin syringe will be problematic. That is the reason I am asking. Because the youngster...
For a newborn, it's always insulin syringe, sir.
Not the syringe, sir. The insulin needle will be problematic, sir.
Oh,
The
that
depth
is
of
right.
the needle might not be enough.
No, yeah, I am not talking
Not the
about
syringe,
it.
sir, the needle.
No. I said intramuscular
Needle.
needle only. I was very clear in my terms. Intramuscular needle only, I said. Syringe only I am asking because so that the youngsters will know while they are practicing. Thank you.
So I have one question to Dr. Madan. So what's
Yes,
the difference in pediatrics, sir? Chronic pains, the malignancy and all.
So chronic pain in pediatric patients actually.
Mainly malignancy pains.
Yes, a malignancy related actually, we do come across these patients. These are one of those very difficult patients because these actually we don't really prefer interventions, sir. We don't really prefer interventions. We
Then what
actually
we give is only oral morphine.
it's a better oral morphine or even a pump, means like an intrathecal or an epidural morphine pump or something like that actually. If actually orally the child is able to take better actually. Typically we do face a lot of these childhood malignancies, particularly the bony malignancies, rhabdomyosarcomas, all these actually, they don't present with one individual structure where we can actually give a pain relief. So generally we do face a problem. Actually, the patient actually do not present with one individual organ where there is a visceral pain actually, where we can do some procedure. They have a multi-structured pain actually, for which definitely I think like oral morphine or even intrathecal or epidural morphine pump will do, rather than actually going in for all neurolytic procedures.
Thank you.
Yes, sir.
Is there any other questions?
Sir, I have one question, sir, to Dr. Madan.
Yes, sir.
Is there any intervention for fibromyalgia syndrome, sir?
Sir, fibromyalgia is something actually, no, sir. Like typically, we need to make a diagnosis. Diagnosis itself is actually by an 18-point chart, actually, a questionnaire, and for which you need to have a proper diagnosis. Confirm a diagnosis with one of your colleague actually to make it, means to confirm it. Maybe a trigger point injection can help, sir, actually. A trigger point injection or maybe a dry needling with or without local anesthetic will definitely help, sir.
How long it will work? How long it will work?
It all depends on how you break the cycle. Initially, you may actually have to do it every week, maybe some 3 to 4 sittings actually. But once you break the pain cycle, definitely there is always a chance that the patient might be amenable to the regular paracetamol dosages.
Chairperson, sir, my question to Dr. Siddharth.
Yes, sir. Dr. Siddharth?
Dr. Siddharth?
Yes, sir.
Yeah, he's there.
Whether, see, in tetralogy of fellow cases, we use beta blockers for cyanide expel. So, will the use of beta blockers will interfere with this thermoregulation of newborn?
I'm actually not quite aware of this, sir. I will need to get back to you on that one. I'm sorry.
No issues. Just for PGs only asked. Actually, for this brown fat metabolism, they require an intact neuroendocrine system. So, by using a beta blocker, the neural stimulation is impaired. So, the patient will go for hypothermia very easily. They cannot burn the brown fat because of lack of sympathetic stimulation. So, we have to be very careful. And a newborn, hypothermia produces hypoxia, hypoxia produces hypothermia.
Yes, sir.
So, that is, see, this is the carry home message I want to give for the postgraduates. I wanted it from your mouth. Thank you.
Sir. Thank you, sir.
Have you ever used intralipid emulsion for toxicity?
Even for adult, we have not used.
No, sir. No.
So far we have not come to that situation, sir. I think I would never want to come to that situation anytime.
Hello, Dr. Dinesh. Even for adult, I think we have never used it.
Nobody uses it. Nobody has intralipid in the theatre.
But that intralipid is becoming a short notes for postgraduates. But we have never used it.
In Coimbatore, we've stocked, sir. Both dantrolene and intralipid, we've centrally stocked it in Ganga Hospital, sir, Coimbatore. So by the time
we have not used it. Nobody has ever used it.
Yes,
that's
sir.
what they are asking, whether you have used it. Dantrolene, many people have used at least across the country. But intralipid, till date, I am not aware that they have used intralipid. Anyone, for that matter, if you know anyone, you please tell me.
And I think by the time we get the intralipid, we would be.
No. Actually, we are managing somehow the routine thiopentone sodium for convulsions and for cardiac arrest again resuscitation. That's how we manage. I don't know. Every time they say intralipid, but I am sure no one have used intralipid. There may not be any time for that. That is my personal view. If anybody has used, we have to learn from him. How he has used, what is the dosage, everything. So in pediatric, absolutely, there will not be enough time or dosage. In pediatric, it may not work.
Yes. But abroad, I have seen, sir, all theaters having intralipid in their.
No, again, I
this thing,
repeat,
emergency
Dr.
condition.
Dinesh, intralipid is a scientific way of treating. It is mentioned. Even a university question is asked. I'm asking, how many people have used it really? They have to say, how many people have used it? Even we are also teaching intralipid emulsion. It should be there in the theater. That is the reason why you have centrally stocked it in Coimbatore. But I want to know how many people have really used it.
Not many, not many.
That is the main point. Then that is the reason why our knowledge is not growing in that line, intralipid. Any more questions, Chairperson, sir?
There's nothing in the chat box, sir.
So you can give your wind-up remarks.
Okay, sir. Before we wind up, I'd like to thank Professor Meenakshi Sundaram, sir, my friend Dr. Suresh, Dr. Pirisamy, sir, for giving us an opportunity. This night's interaction. For the postgraduates, a very good carry-on thing is acute pain, treat properly in the perioperative period, but definitely be aware of the complications. Just don't give opioids and walk out. See that there is somebody to monitor the patient. Otherwise, you just lose the patient for nothing. No part of the patient you lose. Coming to chronic pain, as Sarah said, there are at least learn around 10 to 15 blocks, simple blocks during your postgraduate period, so that once you decide on the type of career that you are going to take up, because anesthesia career is going to change so much in the upcoming decades. So that is the thing. And temperature regulations, it is really, really very important. If you are going to handle any newborn, if you're not careful with the temperature, the patient goes for hypothermia. I have seen so many cases going for reversal. For the surgical newborn patient, they just, without any reason, they go for reversal. If you don't identify the dynamic pulmonary hypertension, which is these children will die. So you'll have to take care, prevent hypothermia. So there's no more questions. I think I'll hand over to Dr. Suresh, ISA Pudukkottai. Thank ISA Pudukkottai for giving us the opportunity. Thank you.
Thank you, sir. Thank you, Krishnan, sir.
Before that, I want to say, see, all the four performed very well. That too, the speakers not formal lecture mode. It was more of an interaction, and everyone was friendly. Everyone is soft-spoken. All the four with the smiling faces. They have done commendably well, and I should congratulate Dr. Siddharth, Dr. Dinesh, Dr. Madan, and Dr. Madan was introduced by Dr. Kingslin, Kanyakumari. So, see the vast knowledge he possesses and the way in which he expresses with a good clarity. Same way, Dr. Dinesh also. And capital, our chairperson, Krishnan covered in a fantastic way, of appreciation for the faculty, and really 79, the top 71 were there. So it is really academic feast. I thank one and all. I hand over the session to Dr. Suresh, our president.
Thank you, ALM, sir. We have witnessed a very wonderful session today. Excellent presentation by all the three speakers. Nice navigation and comments from our chairperson, Dr. Krishnan, sir. Now I call upon our treasurer, Dr. David, to give the vote of thanks. Over to Dr. David.
Good evening to all. On behalf of ISA Pudukkottai, first of all, I would like to thank our academic chairman, Dr. ALM sir, for successfully conducting the 35th webinar. And thank you very much, sir. And special thanks to today's chairperson, Dr. Krishnan sir, professor of MMC, Chennai, for sharing his views. Thank you, sir. I would like to thank today's speakers and Dr. Dinesh Kumar Gunasegaran and Dr. Madan Pondian and Dr. Siddharth for excellent academic session. Also thank other faculties and postgraduates and Akirola A1 Logics for technical support. Thank you all.
A1 Logistics can close the session.
Thank you all, sir. Thank you. Thank you very much.
Thank you, sir. Thank you.
Thank you. Thank you, Krishna. Thank you.
Thank you, thank you, thank you.
Thank you, sir. Thank you, Krishna.
பக்கத்திலேயே உட்கார்ந்து அந்த மசாலா வந்துட்டு